why don't I give this talk again? Well, I've never, ever in my whole life given the same talk twice. There's two reasons for that, of course. One is, well, three. One is because it's boring to me. I don't want to give it the same talk twice. But a lot of people who are on the speaker circuit kind of have the same camp lecture over. I think that's fair to you. The same audience that I had in May at APTA in Phoenix is not the same audience that we have here today, right? So why should I expect that the same talk is going to be useful for you that it was back there? The third reason why I don't give the same talk twice is because I don't give talks. I don't do lectureships. I do discussions. And so most of today, or a lot of today, is going to be based on you, based on the talks you have. Well, I never get the same talk twice. It's actually a little bit more entertaining. How many med students do we have today? Cool. I love being a medical student. I hope you like it. Since we're going to have a discussion today, there are a couple of tried and true ways to get engagement into the talk. Breaking the small groups, that's really popular. A lot of places have the audience response system to click ask for stories and case presentations. I'm going to use another tried and true method, and that's called bribery. I have a stack of Starbucks gift cards here, and every time somebody answers a question that I like, or that the rest of the crowd likes, to get a Starbucks gift card, the question of the medical system in the back. So the first thing you're going to do is make an old man pack a focus. You have to yell. Did you guys hear me okay? I can turn on the microphone, but it's so you need to use the microphone. We have people online who can ask.
Yes, we did.
Of course, yeah. We're in the 21st. Something you don't know as a med student. And I'll tell you, here are the options. Everything, because that's okay as a med student to not know everything, right? So tell me something you don't know.
Everything.
Everything, good answer. Do you know what you want to be as a doctor? Do you want to do?
Maybe pediatric.
So there are two correct answers to that question, right? If I ask that. One is, I want to be a pediatric surgeon. The second is, I haven't decided yet, but I'm thinking about being a pediatric surgeon. All right, so that's med students. How many general surgery residents do we have? So you guys are smarter, you're higher achievers. You're all sitting down here. Who is one over here, general surgery resident? Do you drink coffee? Of course you do.
I do.
Tell me something you don't know. An acceptable answer for you would be some stuff, right? I love being a general surgery resident. You know enough to feel accountable and responsible for making the patients better, so you can be happy going home every day. But the fact of the matter is, there's really somebody else running the service, so you have a lot of. So tell me something you don't know.
Some of the stuff.
Some of the stuff, exactly right. I'm doing too much prompting. All right, how many chiefs do we have? Any chiefs got up this early in the morning? Oh, I guess as a chief's priority, you have to do that. But we have some pediatric surgery chiefs over here. Tell me something you don't know. An acceptable answer for you would be a little tiny bit. A little tiny bit, of course. You're running a big service, right? Everybody looks up to you as the person who knows all this stuff, so you need to know it. Cool. How many attendings do we have today? Super cool. Now, I'm not going to ask you to tell me something you don't know, because I don't want to ruin the illusion that the planet has that you know everything, right? Everybody in this room, all your patients, your parents, they certainly expect you to know everything. So I'm not going to ask you to tell me what you don't know, because I don't want to mess that up for the world. All right. Today we're going to talk about three things. One, oh, sorry, man. Technology. Can you tell I love it? Three parts. We're going to talk about how to decide and how to deal with what you don't know as an individual. Then we're going to talk about as a teacher. How many people are in here are teachers? You all ought to be raising your hand, right? Whether it's your parents, your patients, your colleagues, you all ought to be teachers. What you don't know as a teacher and how that can really hurt you. And then finally, because everybody's got a phone, we're going to talk a little about AI, if you want, if we have time, about AI and technology and education. So those are the three things we're going to talk about. This graph is not the US stock market. This graph is not the number of health administrators we've hired in the last 50 years. This is the number of publications in PubMed based purely in pediatric surgery. Anybody want to hazard a guess as to what this number up here is? the number of pediatric surgery publications in PubMed last year? Just guess. There's a card in it for you. 15,000. Who said 15,000? I'll give you half a card. It's 36,000. No, I'll give you a whole card. Why do the people that always sit in the back who answer the questions? I don't know. 36,000 publications. Now, how many people in this room have committed to a lifelong learning plan? Excellent. You get 2 cards. I don't know any lifelong learning plans that would allow me to keep track of 36,000 articles every year. That's just not going to happen. That also doesn't include how many learning objectives do you think we have in the pediatric surgery, not a textbook? You mentioned that earlier. 29,000. So if you want to know what you need to know as a pediatric surgeon, you need to know 29,000 things to start. That doesn't include the videos and hundreds of hours of stuff on PedSurge TV and all the other platforms that we manage. When I started, this is 1958 when I was born, when I started my career in here, it was hundreds or maybe thousands of articles, and I could have a lifelong learning plan that helped with that. 36,000, I don't know. We're definitely at a point in time, there's plenty of evidence for this, that doctors now need to know more than they can actually know. So we need to figure out why that's a problem. That tells you what you don't know. Before we get too far along, I don't want to bury the lead here. Who can give me a definition of true learning? There's a card in it. Come on, people. You're going to make me start calling on people. Just a definition of true learning. Perfect. Wrong, but I'm going to give you a card anyways because you had the courage to speak up. There you go. So for me, and this is an important point I think we should start with, true learning means eliciting a change in behavior. So there's 2 kinds of learning that we talk about generally. One is addressing knowledge gaps, facts that you don't know. How many lymph nodes do you need to remove when you do an nephrectomy for Wilms tumor? Cool, but that's a knowledge gap that you may or may not know. I don't deal in those anymore. I don't have the time, I don't have the patience. It's literally not worth my investment to deal with knowledge gaps. I deal with something that I think is much more important. Those are practice gaps, not what you don't know, but what you don't do. Do you take out those lymph nodes when you do the nephrectomy for Wilms tumor? I don't care if you know it, but I do care that you do it or not. If you look at medical errors, adverse events, this is for pediatric surgery, completely unpublished data because it is medical errors and nobody publishes their data on that, right? Those things happen for 3 reasons. 1, because the surgeon didn't know what was going on, didn't know the right knowledge. That only is responsible for about 1/4 to 1/3 of adverse events. 2nd, they knew what the right thing to do was, but they didn't apply it to their patient. And that's actually about 1/2 of medical errors. That's a practice gap. The rest has to do with the surgeon wanted to do something, but the resources, the environment around them didn't allow them to do that. They didn't have a ultrasound tech at night, so they had to get a CT for appendicitis, whatever that is. Those 3 things. So the vast majority of adverse events don't come from knowledge gaps, right? They come from practice gaps and how you take care of things. And true learning to me is affecting those practice gaps or eliciting a change in behavior. Why is that such a big deal? Because this is how you learn. If you're going to learn something from me, if you're going to change your behavior from me, it needs to get out into long-term memory. But to get to long-term memory, a concept has to run the gauntlet, the obstacles, if you will, of short-term memory and working memory. Short-term memory remembers how many of you guys drove to work today? You remember the songs that were playing on the radio? You do not. Because in your head, you're driving, you're deciding, well, don't hit that red Toyota over there, or you're thinking about the cases you got to do today, or you're thinking about how am I possibly going to stay awake for this lecture this morning, right? Short-term memory is really broad. It can handle dozens of concepts at the same time, but it only can keep track of those for minutes at a time. When you do a core lecture on neuroblastoma or biliary atresia or colon cancer, you are pouring all that information into short-term memory for the learner. That makes sense at the time, but the fact of the matter is it's all gone in a couple of seconds because those concepts never made it into working memory. So what do you suppose? I'm running out of cards, so the questions are going to get tougher. What do you suppose the brain decides on what concepts move from short-term memory into working memory? How does it decide what's worthwhile? How does it prioritize what you need to know? Super easy question. Emotions are actually, I'm so glad you said that. We're going to talk about emotions later, but what we really need is as an adult, you will remember something from short-term memory to working memory if you have to use it to solve a problem, right? As an adult, we got problems. As doctors, we got patients with problems. So unless we use those things right away, they're through our brain. And of course, think in a long-term memory if you've used it to solve a problem and you can file it along something that's relevant to it as well. So if I want to change behavior as a teacher, if I want to make an impact in how my learners are taking care of their patients, I need to negotiate those steps getting down in a long-term memory. Core lectures, by the way, is not the way to do it. This is one of my favorite graphs in medical education. This data comes from a cohort of internal medicine residents, which in this room probably means that data is faulty. At any rate, this is a lecture given to internal medicine residents, and then they're tested on it right away. 25% is the number of concepts they'd identified from that previous 45-minute lecture. This is right after the lecture. 2/3 of that stuff is gone, right? Pro tip, whenever time you get a talk, you're always given way too much information. You may like saying stuff. They don't always hear, nobody's hearing 3/4 of what you're saying. All right, how many of you, I know the pediatric surgeons in the room. Are you a subscriber of Expert? Ped Surg Library. So we have a pretty sophisticated, I'm pretty proud of, continuing medical education project that most APSA members, most pediatric surgeons in the planet belong to, that sends you every Sunday morning 3 CME multiple choice self-assessment questions with discussions and references and all those other things. Pretty cool. But if you've done that, Dave, you know that every week, one of those questions is going to be really familiar because it's the same question that we just asked 6 weeks earlier. And that concept is spaced learning. You double the retention of the information if you just repeat it within a month to 6 weeks. So that's why you have a repeat question that hopefully you get right. And for pediatric surgeons, our number of correct answers goes from 20 to 40% to 90 to 100% based on spaced learning. Anybody have any idea what the red bar is? Spaced learning is cool, but it only doubles retention. The red bar is when somebody uses that information from the lecture to solve a problem, takes it that day to take care of a patient or to read an x-ray or whatever it is. Solving problems is how you get information integrated through working memory and into long-term memory. All right, let's talk about what you don't know about yourself. And this isn't really right. You're going to have a coaching grand rounds in a couple of weeks, and this guy will talk about that. Guy or girl will talk about this. How do you decide what you don't know? This is super hard, right? You could have told me I don't know about the Krebs cycle, or you could have told me I don't know the pathology of duodenal atresia. Those are things you don't know. How do you know what you don't know you don't know? Is that enough no's? I don't remember. It's really hard. You need a lifelong learning plan. And if you do not have one, you're in trouble. You just are. We don't stop learning when we finish being residents, of course. We learn our whole lives. There's 36,000 articles that I'm behind in reading just this year. So you need a lifelong learning plan. So how do you do that? One, you need to acknowledge that you need a lifelong learning plan. That's not that complicated, and you need to commit to it. We don't teach our medical students or residents. We ask them to learn things, but we don't teach them how to learn once they get out of medical school or residency. So you got to learn that, and that's a lifelong learning plan. If you are a general surgeon, you have the American College of Surgeons that does some continuing medical education stuff. You have your university, you have your department. Those are all community of practice things. Another medical education buzzword that I'm trying to keep out of this talk. But you join a community that helps you learn things. Second important part about adult education theory after the practice versus knowledge gaps. If I am teaching a grade school child, we think of that as an empty bucket, right? You go to school and the teacher just pours information into your bucket because it's empty. Whatever that teacher wants to teach you, you don't know it, so it's helpful for you. You, sir, are not an empty bucket, right? You have a lifetime of experiences. You have things that you've done. Your bucket, I am sure your bucket is like right up to the top already. There's a couple of drops maybe missing from that bucket. So we shouldn't use the same strategies we choose to teach a child, called pedagogy. We shouldn't use those same strategies to teach adults, called andragogy, because you have experiences.
It's leaky.
Well, yeah, tell me about leaky. Yeah, exactly. I had an attending once who told me, Powell, and this is when I was an intern, Powell, I have forgotten more than you will ever know. And I took that as a personal insult, that he didn't think that I would ever know stuff. And of course, 7 years later, when I graduated as chief, he goes, Dave, I told you that because I forget so much, not because you don't know so much. But yeah, especially none of you young people will understand this, but that could be a whole talk about how much information we all lose. All right. So 2 concepts. One is pedagogy. The way we teach kids is the teacher teaches what the teacher wants to teach the way the teacher teaches it, because they think they are the expert. They think they know everything. They stand behind one of these cool high-tech podium things and, one way put the information out. That is not a good way to teach adults. Adults have experiences. Adults maybe know what they don't know. Adults want to be able to file away things in terms of problem solving. So if you're going to be teaching adults, you cannot teach what you want to teach the way you want to teach how you want to teach it. You need to ask them, you need to assess them, you need to figure out what it is. Who's one of our fellows over here? Tell me what you do when you are given the great honor of taking an intern through a laparoscopic appendectomy. Do you just do it? You just take care of it? How do you? Cool. Ask questions. What a great way to do that, right? That's engaging them in problem solving. It's not the answer that you need to ask, though. When I'm at the scrub sink with a new intern, first year got one of these, I don't ask. I don't say we're gonna do this. These are the steps of the operation. And I don't even ask anymore, how many lap appies have you done? That'd be a really good question to start with, right? To kind of gauge where they're coming from, what are their experiences, how full is their bucket. The best question I ask every time when I scrub now is, the last time you did one of these, what was the hardest part of the case for you? Was it just accessing the abdomen if you're a brand new intern? Was it finding the appendix in this sea of pus down the right lower quadrant? Was it positioning the stapler or whatever instrument you guys are using for the appies? That identifies for me what the learner needs the most help with. And then we can spend, because I got 25 add-ons to do tonight, we can spend the most time during that surgery concentrating on exactly what it is will be most beneficial for them. I would never know that if I didn't ask that question, right? All right. So for you as an individual trying to do a lifelong learning plan, you can listen to what APSA says, or you can listen to what the American Board of Surgery says, or you can listen to what the American College says, because they're trying to tell you what they think you should know. And that's great. I love that. They're helping out. We have a really complicated process to try and figure out what the practice gaps are for pediatric surgery. But that is such a pedagogical approach, right? Me as an organization telling you what you need to know. If you're a trauma surgeon, you probably don't need to know about the staging system for neuroblastoma, right? If you are a cancer surgeon, you need to know a little bit about whole blood versus component therapy for resuscitation, right? So in addition to establishing a community practice, which is your university, your department, your division, your professional association, you need to prioritize for you what are the things that you need to know. What is the best way as an individual to learn something? I know you all know this because you've done it. You got to teach it to somebody else, right? I quite honestly did not understand a posterior sagittal anal rectoplasty until I had to teach it to somebody. That's true for inguinal hernias too. Taking someone through it requires such a level of understanding above what just learning the facts does. that I didn't know. So if you want to learn something, and this is totally biased, this is my plug, then you need to write something. For our pediatric surgery non-textbook project, and you know how many authors we have for that project? How many authors does the average general surgery textbook have? 100? We have 800 contributors to the PedSurg library. It's 3/4 of the pediatric surgeons in the United States are contributing to that. And they're not writing whole topics like neuroblastoma or biliary atresia. We have it broken down in little nuggets, so they're writing a single learning objective, like the staging system for neuroblastoma. And why did they write that? Because they identified for them it was a practice gap. And if they're going to learn about it, then it probably means that there's a bunch of other people who don't know it as well. They can write for it and it can go into our big bin of not a textbook. And that's why I have 27,000 learning objectives there. I didn't write 27,000 things, but I got 700 people who do. All right. Let's talk briefly about how we're doing for time, 7:30. Let's talk briefly about this. There are the number 1 and 2 reasons why doctors are stressed out today, burned out, all that other stuff. The first is because they are asked by their healthcare system to deliver care in a way they don't want to deliver it. In other words, they want to do this, but the system requires them to do that. Moral compass, all that other stuff that you probably have grand rounds coming up on that. I'm not going to talk about that. The number 2 reason, especially for surgeons, for stress is because every day you find yourself in an uncertain environment where you don't know what's going to happen, right? It's a super problem. It's super stressful. So how do you deal with that? There obviously are people, this is actually, there's people who can handle stress better than others. There's people who can handle uncertainty better than others. It's just as part of your makeup. And quite honestly, although the right answer to the question was, I want to be a pediatric surgeon. If you are someone who doesn't deal well with uncertainty, you probably shouldn't be a pediatric surgeon, because all the pediatric surgeons in this room will tell you, we are uncertain every day of our lives. It's just a system. Even if you know everything about necrotizing enterocolitis, I never know what's inside it. It could be a little tiny spontaneous perforation. It could be total dead gut. I never know. You need to be prepared for that. How do you deal with uncertainty? And we do this all the time as surgeons, right? First, you need to figure out that there's ambiguity, probability, and complexity. There's no way that you're going to learn everything, right? Okay. You need to be proactive rather than reactive. Kind of think through what's going to happen. What are the options? What are the things that might happen? So that you're not in a uncomfortable space when you deal with uncertainty. Be creative and inclusive. The hardest part is acting even when you're unsure of the outcome. All right. There's ways to deal with that though. Preparation, of course, prevention is the best medicine, right? So how do we prepare ourselves to deal with uncertainty? Why don't you acknowledge anxiety? If you are in a spot and you're anxious about it, anxiety is a super well evolved emotion. If you are anxious about something, that's your body telling you something's going to happen and you need to pay attention to that, right? How many of you guys have mock oral exams here? I bet you do, because we can talk about whether that's worthwhile or not. I think it is, but there's schools of thought. But when you do mock orals for a resident, you probably have a pretty well described script of the patient. 17-year-old who comes in with obstructive jaundice and stones on the ultrasound. And then you go down through that storytelling with the person you're giving the exam to or the mock orals to, and provide more and more information. It is hardly ever the case that you go 17-year-old with obstructive jaundice and the ultrasound machine is broken, right? It's hardly ever that you will give that story in one of those case presentations without purposely introducing uncertainty. But you need to do that because real life is uncertain. So some of these mock oral things, I would encourage you to get to a point where the examinee asks a question, you just go, I don't know, make it up, figure it out. You're going to have to do that in real life. That's the way it is. So prepare for that. What do you do when you find yourself in an uncertain place? First, review what you do know. You probably know more in that situation than you think you do. 2, set priorities. In other words, is the goal to get this patient out of the operating room alive into the intensive care unit with a damage control laparotomy? Or is this a last-ditch effort to save a kid with cancer that doesn't respond to chemotherapy, so you need to do a total resection. Those are different priorities and it will help you guide you what you need to go when you're in an uncertain spot. Make multiple sequential decisions. So don't make one big decision like, we're going to take this tumor out or not. Break it down into smaller parts. Like we're going to start at the superior pole because that's probably the safest part and we'll start peeling that off. And if we get into trouble, then we'll change our mind and we'll make a different sequential decision. You also have to deal with probabilities. Surgeons are not good with probabilities. We're kind of black or white binary, operate or not operate. It's appendicitis, it's not appendicitis, all those other things. Surgeons are not good with probabilities. But when you find yourself in an uncertain space where you may not know yes or no, up or down, true or false, A or B, you need to deal with probabilities. That kid with 17-year-old with obstructive jaundice who has gallstones on an ultrasound, what's the probability? Because I don't really know whether the stone's still in the common duct. Well, I do know what the probability is. That right now it's probably 100%. Tomorrow it's probably going to be 5% because they're going to pass the stone. I may not know for sure, but I can assign probabilities to those uncertain situations and help me deal with that. All right. And then finally, we talked about community. Ask your friends. Thank you for the oxygen in the room, but it's killing my throat. All right. So that's what you do when you don't know what you don't know. What do you do when your learners are trying to help you out? We talked about it a little bit this earlier. Who's this guy? Ted Lasso. So I could show this gratuitous video, we'd all laugh and we'd be 5 minutes gone of our lives and we'd learn something, but instead just do the QR code. This is a YouTube video from the dart scene for Ted Lasso. And if you haven't seen that, this is required watching. And if you have seen it, go watch it again because it is a good, I'm just gonna take a little sidebar. We complain so much about how negative media and the TV and violence and all that other stuff on show. It's amazing to me that one of the most popular shows on television today has a really good message to it. It kind of gives you hope for humanity. All right, that's enough of a sidebar. Watch Ted Lasso. All right, let's talk about learner assessment. How was your week? It was all right. So that means you're teachable, that you said all right. What if you had said, I had this multi-trauma patient, all these things were broken, we were bleeding to death, I had to put my finger in the hole in the heart, and and then the kid went home like 3 weeks later. You would be joyful that you had solved that problem, right? You would be over the moon that you had, we call it in pediatric surgery, we don't call it saving lives, we call it saving lifetimes, right? You had saved that child's lifetime. You are Superman or Superwoman, super person, I don't know. You are over the moon joyful. You are not teachable if you're that person, right? There's nothing you need to know. You think you're perfect. You think you're excellent. You are not teachable. What if I had said, how was your week? And you said, I had a really bad complication. I lost a patient. I made a mistake. Well, there are a lot of places, and when this happened to me, there usually would be a senior partner who would come up to me, put his or her hand on my shoulder and go, Dave, I'm sorry that happened, but this is a teachable moment. It is not a teachable moment when you have a bad complication, right? You're in this misery area up here. You're grieving. You have to repair. You have to recover yourself from having that complication before you're willing to take any input from the outside. So please do not try to support a colleague by using the words teachable moment. You can help them grieve if you're a grief counselor or whatever that is, or a peer counselor. Emotion is super important for learning, right? It's integral to everything we do. So if you are at the joy end of the scale, you are not teachable. If you're at the misery end of the scale, you are not teachable. We are most teachable when we're negotiating this space right in here. When you're no longer so joyful that you realize, hey, maybe there is something I don't know and I can be taught. But when you're miserable and coming up here, you know what? I'm starting to get over that. It's time for me to be better at what I'm doing so that doesn't happen in the future. So stop using the word teachable moment when you have a bad complication. Let's skip this. Unless you guys want to talk about disorders of sexual development. Here's a pro tip. If you're giving a talk and this is your student, you didn't listen to them. You were trying to teach them things that they didn't need to know or didn't want to know. And that's why that DSD talk, I used to give a great DSD talk. It was just awesome for me. But none of my students learned anything about it. All right. Here's another movie we could play some clips. How many of you seen this movie, Mr. Holland's Opus? Just the old people. Have you youngins not seen this movie? So if you are into education, and this is secondary, this deals with a high school teacher, just go out and rent or watch or stream or whatever this movie is. There's so many, and this clip has to do with dealing with a clarinet player. It doesn't matter. You can watch, this is on YouTube for free too, but I would encourage you to watch the whole movie. I will share my pro tip for this movie: bring Kleenex. I'm not going to say anything else, but bring Kleenex. All right. So what have we talked about? Or what do you talk about when you're assessing the learner? Who are the learners? What do they already know? What do they need to know? Remember, that question is not what do you want to know, but what do you need to know? You may not know because you don't know what you don't know. And how will they best learn it? If you're not doing those four things, you're wasting your time, you're wasting their time. All right, finally, how much time we got? A couple minutes? How many people in this room use ChatGPT? All right, whose hand went up first? I'm going to give this to you. What do you use ChatGPT for?
I use it in the lab, looking at certain genes.
So expand on that a little bit, because that's a really cool thing. You don't think you can look at them yourself?
Well, I want to know what research is out there already for.
Super, super good. I think we talked about this analogy last night. I think of ChatGPT as a visiting professor, right? You ask a visiting professor a question, they'll give you an answer based on the huge amount of experience they've had in their lives. ChatGPT uses as an experience all of the public domain internet. So it's got a ton of information out there that you may not know about. It's really good. Just kind of sometimes visiting professors are good. But ChatGPT, just like that visiting professor, will base his or her answer on his or her bias. Same thing for ChatGPT. We all know you can believe everything you read on the internet, right? ChatGPT uses that maybe unreliable source, certainly biased source answers. So like a visiting professor, it'll always give you an answer, but it'll always bias that answer. Have you ever asked a question of a visiting professor and they've said, I don't know? That has never happened in my life, except when I'm the visiting professor and I say it all the time. Have you ever asked ChatGPT a question and it goes, I don't know? No, it's a commercial product developed for CEOs to help understand their businesses or whatever that thing is. If that product gave as an answer, I don't know, they're not going to sell many billions of dollars worth of software for that. So ChatGPT will always give an answer, will never not give an answer. There's a term in generative AI called hallucination, which is the AI model making up just because it's not allowed to say no. It's not allowed to, and it's like a visiting professor. He's never going to say he doesn't know, right? The final thing about ChatGPT is you really don't know what the audience is. ChatGPT doesn't, remember we talked about if you want to be efficient with your learners, you need to ask them what they need to learn, how they need to learn. ChatGPT is never going to ask you, are you a research scientist? Are you a mom who wants to know about gene therapy for something? It's the same answer no matter who the audience is, right? I don't think that's very good. If you are an expert subscriber, pediatric children expert subscriber, how do you figure out what you don't know? Well, the fact is, although ChatGPT and generative AI is a new thing, we've had AI in our learning project for 10 or 12 years now. If you go into expert, there's a tab, that says for you. This is an AI model that sees which questions you've gotten wrong in the CME product. It sees what you are reading in the NAT, so it can kind of figure out what your area of expertise or wannabe expertise is. It gives you readings, and then this is awesome. This is spectacular. I don't think anybody else on the planet does this. Then it gives you a reading list of articles that you should read if you want to fill out things that you don't know when you don't know. I think that's a pretty good use of technology, to be quite honest with you. Now, this is mine. I do a lot of testing, so this doesn't mean I have this many practice gaps. All right. Any mathematicians in the room? Does anybody know what this means? Does anybody know what a hesitant fuzzy linguistic set is? That's really bad because I don't either. I don't have any idea what this means. But this is ChatGPT. This is actually the mathematical representation of that case we talked about earlier. How do you decide how to take care of a kid who comes in with obstructive jaundice and gallstones? ERCP, lap chole with IOC and duct exploration. You just hang out for a little while. Do you MRCP? All those other things. That is a kind of complicated thing to work through. So that's what this is. This is just a mathematic representation from some medical informatics article. This is what I'm reading now. God help me. I don't understand what this means, but I'll tell you what it should mean for you. That ChatGPT is not a pediatric surgeon. ChatGPT is not a doctor. ChatGPT is a mathematician. This formula breaks down all those things that you're deciding about with your patient, just gives it a number, and the computer does the math. I don't want a mathematician making my clinical decisions. I want a doctor making my clinical decisions. So you need to realize that ChatGPT, generative AI, clinical decision-making tools that are based on technology are just doing math that is way too complicated for all of us, but they're not really doctors. One of these days, maybe I'll figure that out. I don't know. No, I'm never going to figure that out. I'm sorry. If you ask ChatGPT, how is ovarian torsion managed? The answer is oophorectomy. Is that right? It is horribly, horribly wrong. It is horribly, horribly. That's what it used to be 10 or 15 years ago. Assess the ovary. If it looks dead, you take it out. I'm using this example because we have general surgeons here who probably aren't getting much gynae training, but eventually you're going to do an appy and it's going to be an ovarian torsion, so you need to know this. Horribly, horribly. It turns out that I have to admit that I don't know what I don't know. So when I look at a black or a blue ovary that is twisted, I don't know whether that ovary is going to live or die. I just don't. So you untwist it and you leave it in place. You do not, as ChatGPT says, do an oophorectomy. Why does it say that? Because it's using old data from the internet before new studies that show that clinical decision-making for ovarian viability is really, really bad. It's talking to parents or patients, not to doctors who understand the nuance of leaving something that looks dead inside because it might be alive, who have done the histology and the pathology and know that these are live ovaries. People are using this to make decisions, and it's just not right. So we have a version, generative AI model we call APSI, APSI, which is augmented pediatric surgery intelligence, not artificial. There's nothing artificial about artificial intelligence. That's a bad name. So this is the APSI thing that will come live probably Christmas time. It'll be a Christmas present for us all. And it says, primary approach, detorsion without oophorectomy, because ovarian preservation should be prioritized, all right? That's the right answer. So why is that right and ChatGPT is wrong? Because this model uses only vetted evidence-based sources. It doesn't use all of the internet for its things. Everything that's on here has been reviewed. Every piece of data that goes into APSI, the questions haven't been reviewed by a human, but all the data, the content has been that it's synthesizing from, right? And we know that this platform is being used by pediatric surgeons. We know the audience, so we're tailoring the answer just to the audience, all right? So I think generative AI is great, but you need to realize those caveats. The information comes from anywhere and may not be true. It's never going to say, I don't know. This platform down here tells you not only the source of your information, but it gives you a critique of its own answer. ChatGPT is never going to critique, is never going to be critical of itself. And if you don't get the answer, then you just click this button and it does a literature search, highly intelligent literature search for you to get your own information. ChatGPT is never going to do that, but ChatGPT isn't being used to make decisions to take care of people and children, and this is. So it needs to be a little bit better. All right, what have we talked about? We're done. Dealing with uncertainty, assessment of learners, and caveats about technology. We have a few minutes left for questions, comments, and more importantly, I have 2 cards left. So the 2 best questions get, I'm assuming everybody in here except me drinks coffee. Would it be better if I did like an Amazon gift certificate? No, you're living and dying while you're Starbucks, all right. What questions do we have? We had a ton of questions last night, super good discussion about that. All right. How many people are going to go home today and put together a lifelong learning plan? Are you killing me? At least one person raised their hand. Okay, good for you. All right, and you have a question, so you get a card either way. All right.
But how can you create like a lifelong learning plan and you are asking yourself every day what things you don't know? So you are adapting this plan daily, weekly, monthly.
So say that louder, because does everybody hear what he's saying? No. We have a microphone. Hold on. Oh, here it comes. Super good question, right? First, he's talking about how often you change. Let's go ahead. Excuse me.
Thank you. So my question was, if you are creating like a lifelong learning plan, right? But it's mandatory just to ask the things that you don't know. So how often are you adapting this lifelong learning plan?
What do you think would be good? How much time are you willing to spend on this?
So I think that the perfect or the idea would be like daily, but I don't think that I will have time every day just to
Super
adapt,
hard.
right?
I don't have
So-
time in my day to do this. So there's two ways to answer that question. One is, for most people, when we're talking about lifelong learning plans, we're talking about a weekly commitment of a couple hours to review the literature, to do the reading list that the program suggests, or to figure stuff out like that, a couple hours. But a better way, remember we talked about you're going to really learn stuff if you're using it to solve problems, is to just be more aggressive about doing a literature search or looking in the NET or asking APSI something when you have a real problem, right? When you have a problem you're trying to solve, that means you're going to do it as well. And that's why APSI's on a phone. That's why you can do that anywhere you want. That has to do with kind of doing what the rest of the planet thinks from a pedagogical view you need to know. I think it's much better to do it from your individual andragogical approach, where you figure out what you need to know based on the problems that you're dealing with today. All right. How does it, Department of General Surgery, does it have a core lecture series? Not the best idea, right? You got to do it because you've got SCORE that has your curriculum out there and you know you got to cover all this other stuff. But the fact is that core lectures are not a really good way for your residents or us to learn. A better way, and we do this at Stanford, and I've done this in DC, is have a curriculum board. Little white, actually it's a big whiteboard for pediatric surgery that kind of lists all the things that you should know about appendicitis, biliary atresia, all those other things. And then when you have a patient with obstructive jaundice as a newborn, and you need to figure out whether they have biliary atresia or not, that's when you give the biliary atresia lecture, and then you check it off your curriculum board. We've done it that way. Or when you have a patient with neuroblastoma, that's when you go through that complicated INRG staging tree that none of us can ever remember, and I need to look up every time I have to have a patient with that. So if you do problem-based education like that, that's contemporary with the problems, that's much better, and that's how I would do my lifelong. That's how I do my lifelong learning plan. Every week I have a Zoom with the pediatric surgery fellow, and she'll ask me stuff. I don't know. I'm not ChatGPT. I don't know. So I'll go look it up. That's what I'll do my little thing for, and I'll get back to her on whatever the answer is. So that's what I would suggest. Once a week for a couple hours is kind of what people talk about, but a better way is continuously based on when you have patient problems. All right. One last card and 5 more minutes. Did I already give you a card? All right, good.
Comment first. Thank you so much for giving this. This really makes us think outside the box, away from these dedicated core lecture series. My question comment is, I think one of the unique things about surgeons is how seriously we take M&M. And I've learned so much from making mistakes. We all hate to make mistakes, but I've probably learned more from watching other people make mistakes and learning about what the options were, what decisions they made, why that perhaps was not the best decision. And I'm surprised that other fields in medicine don't take M&M as seriously as we do.
Well, we're the ones who started, surgeons started M&M, right? And I'm sure you guys, have M&M conference. It is the best thing ever. But I will say that there are a lot of programs that have, based on adult learning theory and all these other things, have evolved their M&M experience, right? To be a little bit more evidence-based, to be less blame, less negative. The great UCSF now has the opposite of M&M. Forgot what they call it. It's like their SAVE conference, where people bring their, yeah, no, it's not. It's where they bring their best cases, their best saves in, so that everybody still gets a chance to benefit from the things the rest of the team learned, but it's less negative. It's less, man, they saved that trauma kid. That was super cool. Or that congenital, that complicated anomaly thing. So share, that's what, M&M is good. You have to be careful that it's not a court, right? That it's not negative. And think about maybe every sixth M&M, making it be a opposite of M&M, bring us your best saves. And we'll talk about those as well. It's also a little bit more uplifting experience. And Lord knows we all need more of that.
It's a question I'm asking because I really want to know the answer to it, not because it's necessarily a patented great question. I would say that the percentage of the content that you offer, that your audience takes home and remembers, is probably substantially higher than the typical person that gives a presentation. And watching you interact, it's, to my mind, it's because you sort of left the podium and came out into the
Sure.
audience. It was interactive. It wasn't you sort of looking at that. When did you learn to do that, and how did you learn to do that? Because it's a completely, why, thank you, a completely different approach than we oftentimes see. How do you pull that off?
Super good question. And I'll share with you, remember that slide where it was like 25, 50, and 75? That was a lecturer standing in front of a podium talking to internal medicine residents about, I forgot, lung disease. I think it was chronic obstructive pulmonary disease. So that was your more typical pedagogic approach. And I hate using those words, but there's just no word that's better for it. Teaching adults like children is what that is. And what could go wrong? At any rate, I don't know that those numbers apply to a more modern adult learning theory based educational experience. So when did I learn this? The reason I say that's a great question is that I had a really good opportunity. Dave mentioned it earlier. When I was a junior attending and I decided education was something I wanted to make my career at, we all need careers. We all need stuff. There was a brand new program starting down the street at George Washington University called the Master Teacher in Medical Education program. And it was the second year of the program, but the first year it didn't happen because nobody signed up for it. Nobody knew what that was. Nobody knew how to do that. Nobody was getting a master's in education anymore. So I signed up for it. 2 surgeons, 10 pediatricians, a couple of radiologists. It was life altering for me. It just was. That experience of doing a deep dive into what this adult education is new for medicine, but it's not new for corporate America, that has to teach its people how to make widgets, or it has to teach its managers how to run budgets. This concept has been around for a long time. It just hasn't made it into medicine until recently, until people start walking around outside the program. So that master's in education for me was a transformative, and I don't use that word hardly ever in my life, transformative experience for me. The point being that not all all need to go out and get masters in education, but you need to pursue some part of your lifelong learning plan, some additional in-depth study and creativity of a field that is outside of what you already do. So I would encourage you all to you'll fund stuff, right? Yeah, of course you will. Because it's going to make you better, and it's going to make the rest of the department better to have you there as an expert, right? I will say also, this isn't just for education, right? If you have a committee meeting and you're in chair of that committee, and you don't ask the people of the committee what their goals and what they want to get out of that committee meeting, you just go in there with your own agenda, fail, you're gonna land flat on your face. So this is part of leadership coaching, right? This approach of figuring out what's going on. It is this approach that was transformative to me changed how I never would have been APSA president if I didn't have this experience, because I would never have been smart enough to ask people, what project do you want to do next? Or how do we want to be successful at that? It's really important to get more study and to apply that to the whole part of your life. Does that answer your question, kind of?
It does, thank you.
It's super, it's enough for me to make a career of it, even when I should have been retired like 4 times ago, as my CV says. Any other questions? We're like 8:01, so I'm 1 minute over, I'm sorry. Thank you so much for your time. I appreciate the opportunity to be here. I hope